هنتكلم على البوست ترانسبلانتس بيكي
لا لا
فيروس.
أحمد
اتفضل.
بسم الله
معاك
الرحمن
ياسر.
الرحيم. بسم الله الرحمن الرحيم. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And today we have two of the great coming speakers of CME chapter and transplantation in Egypt. They are young in age but great in science. We have Dr. Mu'tasim al-Sayed and Dr. Rami Abu Bakr. And I am really pleasured to co-chair this session with Professor Ahmad al-Thaqabi, my dear friend, who is the head of Professor of Nephrology and Medicine in Mataria Nephrology and Urology.
National Institute of Urology and Nephrology.
National Institute of Urology and Nephrology, and the head of Nephrology Department in Mataria National Institute of Nephrology and Urology. He is ESNT board member. We will have two lectures today about the viral infection in kidney transplantation presented by the two coming stars, speakers stars, and we have the two lectures one by one and come to the discussion after the two lectures. Let me welcome all the attending professors who are sharing us. I can see Professor Dawla Bilal, Professor Saeed Khamis, Professor Faisal Shaheen joining us, and more are joining consequently. And welcome to all attendees. And of course, I am to thank also Dr. Rami and Dr. Mu'tasim for all of their work in addition to their work in transplantation and usual work in their centers in CME chapter meetings of Egyptian Society of Nephrology and Transplantation. I will leave the floor to Professor Ahmad Thaqabi to introduce the first speaker, Dr. Mu'tasim, and we'll come to you again after the end of these lectures to share in this discussion. So please, Dr. Ahmad, start.
Okay. طبعا initially I will thanks Professor Yasser for invitation to me as a moderator for this meeting, and today we'll have two lectures. The first lecture by Dr. Mu'tasim al-Sayed. He will present to us post-transplant Becky virus infection. Dr. Mu'tasim is a lecturer in Mansoura Urology and Nephrology Center. And as Dr. Yasser said, it is one of the stars in transplantation. Dr. Mu'tasim, please, you can start, please.
Thank you, Professor Ahmed, for your kind introduction, and many thanks for Professor Yasser for his continuous efforts in CME chapter activity. I'd like also to thank my professors and colleagues who are attending this meeting tonight. And I hope all to enjoy my presentation, which is about BK polyomavirus nephropathy. BK virus is a DNA virus that belongs to polyomaviridae family, which includes PK, GC, simian virus 40, and other viruses. BK virus is an abbreviation of the name of the first patient whom the virus was isolated from. It was initially isolated from the urine samples of a 29-year-old kidney transplant recipient who presented 3.5 months post-transplant with anuria. And here are some points to concentrate on from the history. Firstly, the patient got infected with the virus in the first 6 months post-transplantation, which is the expected period of having BK virus reactivation. He presented with urethral stenosis, which is one of the clinical presentations of this virus, as we will see. And with a history of treatment for 2 episodes of rejection, meaning that he was heavily immune suppressed, which is the most important risk factor for BK virus reactivation. And lastly, the virus was isolated from the urine samples, which is important for diagnosis, as we will see later on in this talk. BK virus nephropathy occurs predominantly in kidney allografts rather than native kidneys. However, it was reported to infect native kidneys in specific situations such as leukemia, heart transplantations, which are considered also as states of immune deficiency. In terms of viral structure, BK virus is a non-enveloped, non-double-stranded DNA virus, which is formed of 6 viral proteins, 2 early proteins, the large tumor antigen and the small tumor antigen, and both are responsible for viral replication and establishment of latent infection. And other 3 viral capsid proteins, VB1, 2, and 3, which mediate cell entry. And lastly, non-coding control region, which is associated with high BK viral loads. What about the mechanism of viral entry into the host cells? And what is the role of viral capsid proteins, as we mentioned before? As we can see in this figure, BK virus enters into the host cells, firstly by binding through the viral capsid proteins to a specific cell surface receptors, and followed by internalization of the virus to form a cavula. Then, with the help of microtubules, it will move to the endoplasmic reticulum, and finally, it enters into the host nucleus to be settled there. The primary infection with BK virus is usually acquired during childhood, with approximately 90% of healthy individuals acquire the infection before adolescence. The infection occurs mainly through fecal-oral route or via respiratory transmission. And also it can occur through blood transfusion, organ transplantation, and transplacental. Following the primary infection, the virus establishes lifelong latency in renal, tubular, and uroepithelial cells. And for most individuals who are immune competent, both the primary and latent infections are asymptomatic. They pass without any symptoms because the viral replication is mostly inhibited by neutralizing antibodies and due to destruction of infected cells by cytotoxic T lymphocytes. And still, up to 20% of normal individuals shed viral particles in the urine without having any symptoms. But the situation is completely different in immune-suppressed patients. As with impairment of host immunity, reactivation of latent infection occurs, leading to shedding of the virus in the urine, viruria, followed by viremia and BK nephropathy. And this reactivation most commonly occurs in the first year post-transplantation when the host immunity is most suppressed. To define the role of impaired cellular immunity post-transplantation in increasing the risk of BK virus replication, this study was carried out in which it was found that those who developed BK virus replication showed a significantly lower levels of post-transplant T lymphocytes compared to a pre-transplant period. And those who developed BK viremia were extensively immune suppressed, as measured here in this figure, by significantly lower levels of measured interferon gamma in the post-transplant period compared to pre-transplantation. In other words, in this study, we can say that higher levels of BK virus-specific T lymphocytes predicted successful control of BK viremia after kidney transplantation. As we can see here, that the median frequency for CD8 T lymphocytes were higher in the controller group of infection compared to uncontrolled BK virus infection. And here comes a question. What causes kidney injury? And why viral replication is associated with this injury? Actually, what happens is that as the virus rapidly replicates, it causes injury to the renal tubular epithelium, characterized by activation of CD4 T lymphocytes, followed by activation of both CD8 and natural killer cells, leading to cytotoxicity and followed by inflammation, and finally fibrosis and graft loss. And here in this study, they tried to describe the evolution of BK virus allograft nephropathy using sequential histopathology with monitoring up to 12 months post-BK infection. They compared BK-infected patients to time-matched uninfected protocol biopsies. And as we can see here, the interstitial inflammation was higher and correlated with viral infection, followed by amplified and accelerated interstitial fibrosis and tubular atrophy due to the immunopathological changes that we have described in the previous slide. What about the risk factors for BK virus replication? The most important risk factor is the intensity of immune suppression. That's why replication rates are higher in the early post-transplant period and following treatment for allograft rejection, because at that time, of course, the patient becomes heavily immune suppressed. Okay, this is about the intensity of immune suppression, but what about the type of immune suppressive drug? Several studies suggested a strong correlation between tacrolimus and higher risk of viral replication, while mTOR inhibitors may be associated with a lower relative risk. This is an important study from OBTN, Organ Recruitment Transplant Network, which was published in 2009, and it included a large number of kidney transplant recipients, more than 48,000 recipients. In this study, in this table, regarding the induction immune suppression, rapid ETG showed the highest hazard ratio for BK viremia in comparison to basiliximab, the alpha chain interleukin 2 receptor blocker, which had the lowest hazard ratio. While when it comes to the maintenance immune suppression and regarding calcineurin inhibitors, tacrolimus-based regimen showed the highest hazard ratio for BK viremia compared to a relatively lower risk with cyclosporin, while in the anti-metabolite group, MMF showed a higher risk for BK viremia than azathioprine. So we can conclude from this slide that a regimen formed of both tacrolimus and MMF had the highest hazard ratio for BK viremia, while in the same study, mTOR inhibitors-based regimen showed a lower hazard ratio for BK viremia than regimen without mTOR inhibitors, which suggests a possible beneficial effect of mTOR inhibitors in controlling the infection. However, the evidence regarding mTOR inhibitors is not conclusive, because later on and after the OBTN study and in this meta-analysis, there was no difference in the incidence of BK virus infection in renal transplant recipients receiving mTOR inhibitors-based regimen compared with a CNI-based regimen. Again, in this systematic review, they highlighted 8 risk factors for BK viremia, and only administration of tacrolimus was classified as a risk factor. Other important risk factors include the high-risk serostatus, which means kidney transplant from BK seropositive donor to a seronegative recipient. In this study, they investigated the relationship of pre-transplant donor and recipient BK-specific IgG antibody to post-transplant BK infection. And those couples of donor positive to recipient negative IgG carried the lowest risk of being free from infection. This is freedom from BK infection, as we can see here in this Kaplan marker. Again, the same evidence from a more recent study, donor positive to recipient negative carried the highest risk for BK viremia, as we can see here from the percentage of patients with BK viremia. Other risk factors include donor viruria prior to transplantation. Here in this Kaplan-Meier curve, which represents the time to BK viruria, time to BK viruria was significantly different between both groups, with recipients of BK viruric donors were more likely and they had a higher risk to develop BK viruria, and here also a higher risk to develop BK viremia. Other risk factors for BK virus replication include older age of the recipient, urethral stent placement, because in urethral stent placement, there is increased translocation of PK virus from urinary space into the blood space. Situations of APO incompatibility and HLA mismatch and rejection because of increased intensity of induction protocols of immunosuppressive drugs. Transplantation from HCV positive donors may affect the survival of CD8 T lymphocytes, and absence of HLA C7 allele also may have a risk factor. Another interesting point in assessment of risk factors for PK virus replication is the lower risk of post-transplant PK infection in polycystic kidney disease. As we can see here in this Kaplan-Meier curve, those of polycystic kidney disease as an original cause of renal failure had the lowest risk of PK viremia and PK nephropathy in comparison to other causes of renal failure. And this may be justified and explained by reduced tubular cells susceptibility. The tubular cells of polycystic kidney reduced its susceptibility to PK virus replication because of the abnormalities of polycystin 1 and 2, or it may be justified by the uncertain protective effect of native kidney nephrectomy in patients with polycystic kidney disease, as native kidneys may act as a reservoir for infection. So to conclude the risk factors for PK virus replication, we have a donor risk factors: old age, deceased donor, the donor PK virus serostatus, and absence of HLA-C7 allele. Recipient risk factors, which include old age, male sex, urethral injury, and the transplant-associated risk factors. And the most important of them is the intensity and the type of immune suppression. What about the clinical presentation of PK virus replication? PK virus replication starts with viruria, followed by viremia, and lastly then by PK nephropathy. Viruria affect approximately from 25 to 30% of kidney transplant recipients in the first year following transplantation, and not necessarily to progress to viremia, but even it usually passes without any symptoms, and only it is detected by urine PCR or following microscopic examination of infected urine samples with the specific detection of decoy cells. Decoy cells are the renal tubular cells containing intranuclear viral inclusion bodies. The second step in PK infection is developing viremia, which is detected in approximately from 10 to 15% of recipients following viruria, specifically in those with high urine viral loads and sustained viruria for 2 months or more. Viremia usually passes without any symptoms, but it is very important to be detected because it has a greater predictive value than viruria for progression to PK nephropathy, and it is considered an accepted indication to reduce the immune suppressive drugs. Finally, PK viremia without any intervention may progress to PK nephropathy. The majority of PK nephropathy cases actually occur in the first year following transplantation. However, late onset PK nephropathy may still occur, which is more common in multi-organ transplantation with more intensive immunosuppressive regimen. Again, PK nephropathy is usually presented with asymptomatic increase of serum creatinine, which may cause graft loss if not detected and managed properly. Other manifestations of PK virus infection include urethral stenosis, which was a presentation of the first diagnostic case of PK virus nephropathy 50 years ago, hemorrhagic cystitis, but it is usually common among hematopoietic cell transplant recipients. It may also be linked to some genitourinary cancers, and systemic affection also has been reported. Regarding the diagnosis and the screening of PK virus infection, viruria can be diagnosed by microscopic examination of infected urine samples to detect decoy cells. However, we have to know that decoy cells are not specific tests, as it doesn't differentiate between PK and GC viruses, and it has a limitation being, of course, dependable on the observer experience. Urine PCR is more specific than decoy cells. However, some centers don't use it for screening because 50% of viruria cases will not develop viremia or PK nephropathy. So it is not useful as a marker of diagnosis of PK nephropathy or a marker for reduction of immune suppression, because we still will need a diagnosis of PK viremia by performing a plasma PCR. Also, it is not useful for monitoring the response to therapy because urine changes usually lag behind the changes in plasma viral load upon lowering immune suppression. Finally, in the urine, electron microscopy examination of infected urine samples will detect a cast-like three-dimensional polyomavirus aggregates termed Hoffen, which is specific for PK virus infection. Plasma PK quantitative PCR is the preferred screening test with high sensitivity and specificity. Plasma PCR is used to monitor the patient response to reduction of immune suppression, and most experts agree that a PK viral load of more than 10,000 copies per ml, particularly when sustained for more than 3 weeks duration, is highly suggestive of PK nephropathy. Regarding kidney allograft biopsy, it is considered the gold standard for diagnosis of PK nephropathy, and it requires 2 items for a definitive diagnosis of PK nephropathy. First, the detection of the characteristic cytopathic changes in the biopsy, while the second is a positive immunohistochemistry test using either specific antibodies directed against the viral capsid protein, VB1, or against cross-reacting simian virus 40T antigen. However, we have to know that SV40 staining doesn't differentiate between PK and GC viruses. PK nephropathy diagnosis may be missed in about 30% of graft biopsies because of the focal nature of PK infection. So at least 2 biopsy cores, including the medulla, should be withdrawn and examined. An important clinical point here also is that allograft biopsy is usually not required for PK viremic patients with baseline and normal graft function, because it will not affect, of course, our plan of management, which is reduction of immune suppression as a whole. But the situation, of course, will be different when there is a graft impairment, which will need a graft biopsy. The characteristic cytopathic changes of graft infected with PK virus include interstitial leukocytes infiltrate, together with viral cytopathic changes and the inclusion bodies in the tubular epithelial cells, and as we see here, and positive staining of SV40, immune staining. From the biopsy, differentiating between PK virus nephropathy and rejection in allograft biopsies is very important, because the management is totally different from PK nephropathy and rejection. And diagnosing concomitant PK virus nephropathy and rejection is very challenging, especially diagnosing concomitant cellular rejection and PK nephropathy, because the histological features of tubular interstitial affection is similar between them. However, we can say that if there is an extensive tubulitis in areas away from the viral cytopathic changes, this may suggest concomitant cellular rejection together with PK nephropathy, while the presence of histological features of antibody-mediated rejection, such as microvascular inflammation, fibrinoid necrosis, and positive C4d in peritubular capillaries, is an evidence of presence of antibody-mediated rejection. Okay, in the previous slides, we were discussing, and we were talking about the diagnosis of PK virus and PK virus nephropathy. But what about the screening? What about the prevention of occurrence of nephropathy from the start? This is the importance of screening, because detecting clinically significant PK viremia, which will be followed, of course, by reduction of immune suppression, will lead to prevention of progression to PK nephropathy, and in most cases, and so preventing graft loss. And actually, clinically significant PK viremia is defined by more than 1,000 copies per ml, while if the copies number exceeded 10,000 per mil, this will correlate with biopsy confirmed PK nephropathy. So if viremia was detected by screening plasma PCR, it will be followed by reduction of immune suppression and monitoring of the viral load every 2 to 4 weeks thereafter to ensure that it is decreasing. While allograft biopsy will be considered if there is concomitant graft impairment or if this impairment failed to resolve despite reducing the immune suppression. In terms of frequency of screening, the American Society of Transplantation has adopted a more conservative approach format of screening all kidney transplant recipients for BK viremia monthly until month 9, and then every 3 months until 2 years post-transplant. While the KDIGO guidelines recommended a monthly screening for the first 3 to 6 months after transplantation, and then every 3 months until 1 year. What about the treatment of PK nephropathy? Actually, there is no specific antiviral therapy for PK virus. And the cornerstone in management here is decreasing the immune suppressive medication to restore the host immunity against the virus. The stepwise immune suppression reduction is recommended for kidney transplant recipients with plasma PCR of more than 1,000 copies per mil sustained for 3 weeks, or increasing PCR to more than 10,000 copies per mil, which reflects the high possibility of PK nephropathy. And we have to obtain a basal plasma PCR level for the virus before starting the reduction of immune suppression to be monitored every 2 weeks later on, and until it becomes undetectable for 2 consecutive tests at least 1 week apart. Regarding the order of reducing the immunosuppressive medications, for patients maintained on triple regimen, we can start by reducing the antimetabolite by 50%, and then follow the BK plasma PCR 2 weeks later. And if the PCR level didn't decrease, we would completely stop the antimetabolite. And again, if the PCR level didn't decrease 2 weeks later, we would decrease the TAC dose by 25 to 50%, targeting a trough level between 4 and 6 nanogram per milli, and cyclosporin level around 60 nanogram to 100 nanogram per milli. Whether to start by reducing the antimetabolite or calcineurin inhibitors, both strategies can be performed, and both are adopted by the American Society of Transplantation. For patients who are maintained on steroid-free regimen, if they are receiving only TAC and MMF, some centers may feel less comfortable to use monotherapy with either agents alone. So an alternative approach is to reduce both drugs, and so aiming at targeting the 2 pathways of CNI and antimetabolite with a lower cumulative dose of immune suppression. An important question is also after resolution of viremia or PK nephropathy, when to start to increase the maintenance of immune suppression to the basal level before the infection. Actually, it is a difficult question, and it is an individualized decision taking into, and this decision should take into consideration the balance between the risk of acute rejection as well as the risk of recurrence of PK virus reactivation. Regarding the modification, the idea of modification of immune suppression, although it makes sense, but the evidence regarding this approach is lacking. Besides the main line of management that we discussed, which is the reduction of immune suppression, there are also some added therapies which may be of benefit, and one of them is IVIG. The commercially available IVIG contain PK neutralizing antibodies against all major genotypes of PK virus, and it may be considered to be given for patients with established PK nephropathy who don't respond to reduction of immune suppression, or who have a severe hypogammaglobulinemia characterized by IgG level less than 400 milligram per deciliter. It is given at a dose of 300 milligram per kg every 3 weeks, in conjugation, of course, with reduction of immune suppression, targeting an IgG level of more than 400 milligram per deciliter after 3 months of follow-up. Regarding the IVIG, many studies evaluated the effect of IVIG treatment and most of them showed a benefit in reduction or even complete elimination of viremia and nephropathy. However, when analyzing these results, we have to take them with a pinch of salt, like because other antiviral interventions were administered concurrently with IVIG in these studies. Okay, we have discussed using IVIG as a part of plan of treatment, but what about the preemptive use of IVIG as a preventive strategy against BK viremia and associated nephropathy? In this study, they divided the kidney transplant recipients into 3 groups. The high-risk group, which is characterized by low level of neutralizing antibodies against the BK virus, and this group didn't receive IVIG. And the second high-risk group, which is characterized by also low neutralizing antibodies against the BK virus, but this group received IVIG. While the third group, the low-risk group, was characterized by high neutralizing basal antibodies, and they didn't receive IVIG. After 12 months post-transplantation, the incidence of BK viremia in the high-risk group treated with IVIG was similar to that observed in the low-risk group, and both were markedly lower than that of the untreated high-risk group. Here in this Kaplan-Meier curve for graft survival, we can notice that the high-risk group without IVIG had the lowest survival, which is colored by the red circle. And they concluded that the IVIG may be a valuable strategy for preventing BK virus replication. Regarding leflunomide is a prodrug, and its active metabolite inhibits the pyrimidine nucleotide synthesis, so acting as an anti-proliferative for T cells. In the initial case series following the introduction of this drug in treatment of BK nephropathy, it showed an improvement or stabilization of BK nephropathy cases when used instead of MMF. However, further randomized studies haven't shown a benefit. Its use is limited by uncertain efficacy, the potential for hematological and hepatotoxicity, the wide interpatient level variability of its active metabolite, and the inability to easily monitor it. It is given by a dose of 100 milligram per day for 5 days, followed by maintenance dose of 40 milligram per day, and it doesn't need renal modification. Cidofovir is a nucleotide analog of cytosine that is active against various DNA viruses. It should be considered for treatment of nephropathy when other interventions fail. Only few uncontrolled studies have evaluated the use of cidofovir therapy in treatment of BK nephropathy, and they concluded that low-dose cidofovir therapy resulted in prolonged graft survival and stabilized graft function. It can be given either intravenously or intravesicular. It causes, which is important here, it causes nephrotoxicity. It may cause nephrotoxicity with renal failure, proteinuria, and proximal RTA. And to reduce this nephrotoxicity, it should be combined with IV prehydration with normal saline and administration of probenecid. Probenecid is a uricosuric drug, which prevents the uptake of cidofovir by proximal tubular epithelium. Regarding quinolone antibiotics, randomized trials failed to show any benefit of levofloxacin or ciprofloxacin in either prophylaxis or treatment of BK nephropathy. In this trial, evaluated the role of levofloxacin in prophylaxis against BK virus, and in which recipients were randomly assigned to receive 3 months of either levofloxacin or placebo beginning within days, about 5 days post-transplantation. And as we can see here, there was no difference between both groups in incidence of viruria or viremia or graft survival as a whole. While in this double-blind RCT, again, levofloxacin as a treatment didn't show significant difference in reduction of viremia or offering better graft survival or better graft function. Also, ciprofloxacin as a prophylaxis for BK viremia failed in this double-blind randomized placebo trial and was ineffective at preventing BK viremia. Not only that, but even it was associated with increased risk of quinolone-resistant infections, bacterial infections. Regarding experimental therapies, there are ongoing trials on some other experimental therapies like virus-specific T cells or BK virus-specific monoclonal antibodies. But they are still ongoing trials. Okay. Unfortunately, in some difficult situations, acute rejection can follow the reduction of immune suppression in about 8 to 12% of cases. And actually, the treatment of such cases is challenging as there are no data to guide the optimal management. However, some experts may favor to treat the rejection first by pulse steroid without using depleting antibodies. And once the patient graft survival stabilizes, they reduce immune suppressive medications as a second step. However, and by contrast, others will avoid augmented immune suppression as a whole and will favor a reduction in maintenance immunosuppression only. Regarding kidney transplantation, of course, it is considered a reasonable option and has been successfully performed, but the absence of BK virus replication prior to transplantation is mandatory with complete resolution of viremia. And theoretically, the failed graft or even native kidneys may serve as a reservoir of infection. So nephrectomy, graft nephrectomy, or native kidneys nephrectomy may be of benefit. However, there are no high quality data to support this approach. This is the largest study that evaluated the outcome of kidney transplant among patients who lost their first graft because of BK nephropathy. And as we can see here, the death censored graft survival rate at 5 years was about 90% for BK group and 83% for the non-BK group, which was significant. However, in adjusted analysis, there was no difference in death censored graft survival between both groups. And also in this study, there was no significant difference in the rates of acute rejection or patient survival at 1 year between the two groups. Thank you.
Thank you, Dr. Mutasib, for this elegant, comprehensive presentation. And only I will give one comment, and we'll keep the discussion at the end of this session, inshallah. So from this lecture, we can conclude the best management for BK virus is an early diagnosis for BK virus. So screening is very important for this to catch the infection as early as possible before ongoing to BK virus nephropathy. As once nephropathy occurred, so the graft survival would be much less, or the outcome will be not favorable, and the survival rate of the graft will be decreased, markedly decreased. Regarding I think for management of immunosuppression, usually depend on the value of viremia. If it is more than 10,000, I think we from the start we discontinue the anti-metabolites like Celcept. If less than 10,000, we can decrease to 50% and follow up 2 to 4 weeks. If it is more than 10,000, we can replace Celcept by lefonamide and also decrease the dose of the CNI tacrolimus to level will be from 3 to 5 nanogram per ml. This is usually what's happened in the treatment, because the best treatment, you give many modalities for or many protocols for treatment of BK virus, but the best is to decrease the dose of immunosuppression or modified immunosuppression for this case and follow up to 2 to 4 weeks until BCR will be negative. Thanks too much, Professor Mu'tasim, and we'll shift to Dr. Yasser.
Thank you, Professor Ahmed, and thank you, Dr. Mu'tasim, for your highly illustrative lecture.
Thank you, Professor.
For BK virus. Please keep with us following Dr. Rami lecture for the discussion. The coming lecture is Epstein-Barr virus in kidney transplantation, which will be by Dr. Rami Abu Bakr al-Shahat, MD Internal Medicine. He is a consultant of nephrology in Royal Hospital. He is the fellow of Orlik Kidney Academy of Fellowship in Clinical Kidney Transplantation, and he's the current examiner in MRCP in Ireland College of Physicians. Dr. Rami will speak to us about Epstein-Barr virus in kidney transplantation. So please start, Dr. Rami.
Thanks, Professor Yasser, for this opportunity to present this lecture about EBV virus post-transplant. So I will start my presentation with a case scenario, just to get your attention. So we have 22 years old male patient. He is 3 months post-transplant, and during routine screening, his EBV PCR came in plasma with more than 300 copies. And regarding his kidney function, he is doing fine. He is maintained on triple immunosuppression, including tacrolimus. And last tacrolimus level is 7.3. And also he's maintained on MMF 1000 PD and steroids 5 milligram. So we have multiple questions here. What is the cutoff number or consider this viremia significant? When to start screening for PTLD, and how frequent we need to do screening for PTLD? What is your decision regarding reduction of immunosuppression or even switching to mTORs? Even regarding using of antiviral medication like ganciclovir as a treatment of his viremia. Also using rituximab as a treatment for his viremia. And finally, if this patient developed PTLD, what is your decision regarding his immunosuppression, antiviral treatment, and chemotherapy? So this question need to be answered at the end of the presentation. So keep alert. So our agenda today, we will speak about introduction. Then we will speak about EBV and PTLD, risk factors, clinical picture, screening pre and post-transplant, diagnosis and screening of PTLD, how to prevent and treat EBV viremia, and how to treat PTLD and retransplant. And finally, we will summarize our presentation. So as an introduction, we have to know there is a group of viruses called the tumor viruses. It's including DNA viruses and RNA viruses. And this virus is well known to cause malignancies in humans. Like we all know that hepatitis B can cause liver cancer, papilloma viruses can cause cancer cervix, and herpes viruses can cause Burkitt lymphoma, nasopharyngeal carcinoma, PTLD, and Kaposi sarcoma. And RNA virus, like retrovirus, can cause adult T-cell leukemia. So what is the prevalence of malignancy post-transplant? We all know this, the causes of death post-kidney transplant. The primary cause is cardiovascular events, which is considered 34% of causes of mortality, followed by infection. And the third common cause is malignancy. And according to this study published in CJSN 2021, showing the common cancer post-kidney transplant is Kaposi sarcoma, followed by non-melanoma skin cancer, and third part is non-Hodgkin lymphomas. But according to the cancer-related mortality, non-Hodgkin lymphoma came in the first place. And in some studies showing this is maybe the second cause of death post-kidney transplant. So please attention, we are speaking now about malignancy, which is the third common cause of death post-kidney transplant. And we now know that the commonest cancer post-kidney transplant is Kaposi sarcoma, followed by melanoma skin cancer. And once we are speaking about PTLD, irrespective of histopathology, it's a life-threatening disease with overall survival around 25 to 35%, and maybe even lower with monomorphic histology. So what about ABV and PTLD? ABV, it's one of herpes viruses. It is first discovered in 1964 by Professor Epstein and his group. And it was called a kissing disease because of the mode of transmission. It's oral transmission. And primary infection of ABV can cause a disease called infectious mononucleosis, which usually present with whitish coating on the tonsils and some fever and shivering and splenomegaly, some nausea and respiratory manifestations. And after primary infection, it persists asymptomatic for a lifelong in all adults, but for uncertain reason, in some patients, it can cause B lymphomas, T cell lymphomas, Hodgkin lymphomas, nasopharyngeal carcinomas, and gastric carcinoma. And for our group of post-transplant, it can cause what is called PTLD, which is considered a lymphoid or plasmacytic proliferation, which is occur in setting of solid organ or allogenic hematopoietic cell transplant. And it almost present 20% of all cancers post-transplant. And the cumulative incidence is 1 to 3%. And kidney transplant, which is 50 times higher than general population. And it's a lifelong incidence in all kidney transplant recipients. It's around 20%. It's a very huge number. So why it's happening? What is the risk factor to developing such a disease in our group? There is 3 main domains related to developing BTLD post-transplant. First, immunosuppression. 2, ABV serostatus. And some others like history of pre-transplant malignancies and HLA mismatch. So let's speak one by one. Immunosuppression. Is it related to the degree of the immunosuppression, or it's related to specific immunosuppression by name? So as regards this systematic review of meta-analysis assessing the factors related to post-transplant PTLD and EBV viremia, they found that ETG is the most important risk factor for developing active post-transplant viremia and even post-transplant PTLD with the relative risk 3.9 for viremia and PTLD 3.6. So looks like ETG is a one of main player in this such a condition. And also regarding tacrolimus versus cyclosporin in this study done by Stiami and his group and published in American Society of Journal of Transplantation 2004, assessing 41 patient post first kidney transplant, tacrolimus seems to be associated with higher risk of PTLD with relative risk of 2.03. About antimetabolite and almetuzumab studies doesn't show any significant increased risk of viremia or PTLD after using of this medication, especially MMF. Rituximab, although it's one of the immunosuppression, but its use in peri-transplant period significantly reduced the sequence and incidence of PTLD. And regarding pelatacept, we all know from benefit study and benefit extension studies, this is although it's a weaker immunosuppression and it's less strength in relation to tacrolimus and CNI, but it still increased the risk of PTLD up to there is a warning and it's a contraindication to be used in seronegative patients. What about IMTORs? We all know from CONVERT study, which is studied in 2009, and conversion from CNI to sirolimus. It shows decrease in all risk of malignancies, especially non-melanoma skin cancers. And regarding using of IMTORs as a prevention and treatment for PTLD, it's well studied, but unfortunately cases number is very low, and most of the studies they used other therapies other than just switching to IMTORs. So changing the medication to IMTORs or sirolimus, it's possible to get benefit for prevention and treatment of viremia and PTLD. But maybe it's not only for the drug, it may be also for removal of CNI and its tumor effect. Because by contrast, analysis of de novo sirolimus trials showed no difference regarding the malignancy risk However, even there is increased risk of mortality caused by cardiovascular and infection-related deaths in sirolimus group. And some studies even showed that there is increased risk of prostate cancer in relation to sirolimus. Second risk factor for developing PTLD is serostatus of EBV. As we can see from a Obel's study done in 2009, for patients of EBV seronegative, there is a significant increase of PTLD cumulative incidence in comparison to EBV positive patient. And from this study, we can predict there is an evidence of causality relationship between this viremia and this virus and PTLD from the incidence in relation to EBV serostatus. And even we will study, we'll discuss later another study which showed there is a significant relation between EBV PCR screening post-transplant in relation to PTLD, and showed that EBV viremia and the sensitivity of PCR in diagnosis in early PTLD was around 100%, and the specificity was around 81%, and positive predictive value was around 25%, and negative predictive value was around 100%. And although all of this, still there is a small group, which is around 20% of PTLD, which is seronegative EBV. And from this previous two risk factors, major risk factor, we can predict the pathogenesis of this disease, which is it's considered like our patient, he got infected with EBV, which is usually held in check by cytotoxic T cells, but because of presence of immunosuppression, especially CNI or ATG or whatever we used, this mechanism is get impaired, and finally the disturbed equilibrium between the cell cross and this and PTLD is developed. Again, like we stated before, first of all, viral infection to B cells, which usually killed by primary cytotoxic T cells, but because of immunosuppression, this will not be happen and PTLD will be formed. So what about clinical picture? Clinical picture of PTLD, it's completely different from lymphoma. Lymphoma, the picture of PTLD usually presents with non-specific symptoms like fever, night sweating, and weight loss, and mainly extranodal manifestation. So we are not expecting to see lumps and bumps in everywhere, but usually our patient present with extranodal manifestation and most probably GIT manifestation like diarrhea. And once you do some kind of colonoscopy, you find mass, and do biopsy, and you find this is a PTLD. So what about screening pre and post transplant for EBV virus? Regarding a pre-transplant, we need to do EBV screening by doing serology, IgG, because it's useful for risk stratification, immunosuppression selection, frequency of monitoring, and prevention regimens. We have D negative, R negative, which is a low probability of risk of infection, and D negative, R positive, or D positive, R positive, which is moderate risk. But the most important group is D positive, R negative, which is considered very high risk of infection. And sometimes we consider prophylactic treatment and need more monitoring and more frequency of a checkup using EBV PCR post-transplant, maybe even every 2 weeks for the first 3 months post-transplant. So as we stated before, screening for EBV, it's useful for risk stratification because we have to know the high-risk group, which can develop PTLD 6 times more than D positive, R positive, which is considered moderate risk group. And even for immunosuppression selection, because such a group platacept will be contraindicated. And even for induction therapy or maintenance therapy, we have to do some modifications. What about frequency of PCR checkup post-transplant? For lower risk group, monthly EBV PCR for the first 3 months will be enough, even every 3 months from the 3rd month until the 1st year of post-transplant. Otherwise, for high-risk group, which is D positive or negative, fortnightly, which is bi-weekly screening for the first 3 weeks is needed, and then monthly for the next 3 months, from 3rd month to 6 months, then every 3 months until the 1st year post-transplant. What about post-transplant virus screening? Only PCR can be used for screening. Serology is not a valid tool. And we have a problem regarding using PCR because we have different strategies. Frequency of monitoring is different. Definition even for high-risk patient is difficult. And cutoff used to determine the ABV positivity, there is no cutoff. And some centers using screening in plasma and some others using intracellular with different results. And the specific and the best modality is not established. So I will show you regarding using of ABV PCR, prospective study done by Bordeghini and his group in 2002. In this study, they used PCR in peripheral blood monocytes. So they are looking for the virus inside the cells and using ABV viral load as a cutoff more than 300 copies. And once they used this cutoff, the sensitivity of PCR in detection of and diagnosis of ABV-related PTLD was 100%. Sensitivity was around 81%, and positivity predictive value was 25%, and negative predictive value was 100%. By other group, which is Van Eser and his group in 2001, they used ABV PCR in plasma. They didn't use it in intracellular. And for this study, they use another cutoff, 3,225. And for this cutoff, the prediction of PTLD was highly significant. And with this patient with viremia less than 740 copies, the risk of PTLD was significantly lower. So as we see, some people using screening in plasma and some centers using screening intracellular, and there is no cutoff clear. And we don't know what is the significance of these numbers. And we don't know if we have to test it intracellular versus plasma. And so we need to discuss with our virologist, our ID, and we have to look for the trend of viremia, and it looks like it's a more relevant than a specific cutoff number. Using of PCR is not only for diagnosis of PTLD, it's also for prognostic values. So even for this study, which is also done by Van Eser, they saw that patient who received treatment and the cut of the ABV DNA decreased dramatically after 72 hours after initiation of treatment. Those patients responded and PTLD was clear. On contrast, all this non-responder, it shows the same in the same time ABV DNA was not responding and even increasing after management. And even for ABV negative disease, it's usually carry poor prognosis. So screening for ABV PCR is helpful for diagnosis, even for prognostic value, even for negative patient, it's carry poor prognosis. How about screening for PTLD? We did the screening for the virus. So we need to know how to do screening for the malignancy. Screening for the malignancy, first of all, any patient present with non-specific clinical finding, especially even with extranodal manifestation, as we mentioned, like persistent diarrhea, we have to put in mind that this is maybe the underlying cause, it will be PTLD. Timing in relation to kidney transplant, as we can see in this figure, there is a significant increase in first year post-transplant. Then in it will decrease till the 10 years post-transplant, then started to increase again. So if the patient start to they present with any specific symptoms, especially in first year of post-transplant, we have to be vigilant and we have to screen for PTLD, especially if this patient is high risk group, taking a kidney from D positive or negative. And even ABV screening PCR is a valid tool for screening for PTLD. If your patient has a laboratory finding like unexplained anemia, thrombocytopenia, elevated LDH, hypercalcemia, hyperuricemia, monoclonal protein in serum or urine, so you have also to be vigilant regarding predicting maybe the underlying cause is PTLD. Once you are suspecting PTLD, you can either go for BAN-CT or PET-CT scan. And finally, for final diagnosis, you have to do histopathology diagnosis. For histopathology, we have WHO classification. We have 4 main categories: early lesions, polymorphic, and monomorphic, and Hodgkin lymphomas. And we can see once it's in early stages, the differentiation is lesser, and the more relation to ABV status. And once the cancer starts to be well differentiated, monomorphic, it carries a very poor prognosis, and its relation to ABV gets lower. So again, as we can see, primary infection of B cells started to replicate. As we can see here, the color from the cells started to be monoclonal. So monoclonal expansion, so on, start to be more differentiated to monoclonal PTLD. So how to prevent and treat viremia? We are speaking now about viremia. This patient didn't reach to PTLD. So we have either going for vaccination, reduction of immunosuppression. For seronegative patient recipient, avoiding of D positive or negative, it's always favorable if we have multiple options or multiple available donors. Using if antiviral prophylactic like acyclovir or ganciclovir, and preemptive rituximab therapy for patient with high risk of ABV associated PTLD. Let's speak for every single one. Regarding vaccination, NIH launched a clinical trial about ABV virus vaccine in 2022, and this vaccine is was associated with reduction of asymptomatic primary infection and infectious mononucleosis, but unfortunately, it doesn't reduce the incidence of latency, and latency is the most important for our cases because it's associated with PTLD. So more studies are needed. Regarding reduction or even switching to intours, we previously know our victims, and we know our insults like ETG and tacrolimus. So optimum method is still unknown, and regimen varies from center to another, and it should be based on patient to patient, and risks against benefit should be considered based on patient history, immunological risk, and timing for transplant. The conventional is to stop either CNI or anti-metabolites and reduce the others. Until the conversion can be considered either for prevention or for treatment of PTLD. What about antiviral? This is a study done in multi-center case control study, and it showed using of antiviral, it was associated with 83 reduction of risk of PTLD. And for every 30 days of antiviral use of ganciclovir, it is decrease the risk of PTLD around 38%. And for use of acyclovir, it's an odd ratio, decrease around 0.83. So another study, which is done for liver allograft, they dividing the cases for as a high-risk group, which is D positive or negative. And for such a high-risk group, they give intravenous ganciclovir for 100 days, which is quite strange for a pediatric cases doing a liver transplant to admit them and give 100 days of IV ganciclovir. And for low-risk group, they just give IV ganciclovir during a period of hospitalization, followed by oral acyclovir for 3 to 6 months post-transplant. And ABV viremia without PTLD, they only reduced the immunosuppression targeting tacrolimus from 2 to 5, and patient for PTLD, which is defined as a histopathological evidence of B-cell proliferation. They mean they only included the early stages. They treated with intravenous ganciclovir with withdrawal of tacrolimus. What about result of this study? Among 18 patients with high risk of PTLD, no cases of PTLD at all, and one case developed ABV viremia, and even he resolved it after this management. And among 22 low-risk patients, 2 cases of PTLD occurred, and both of them resolved after only tacrolimus stopped with intravenous ganciclovir. But we have to be vigilant. Also, this is a liver transplant. Their targeting for immunosuppression is lower than us, and using even dual immunosuppression like this study, they are not using MMF. So it's a little bit different from our group. And for finally, there is a systematic review about using of antiviral prophylactic for PTLD in solid organ transplant. As we can see on the upper part diamond here on the upper side, on the left side, on the right side, it showed non-significant effect of antiviral in prevention of PTLD post-transplant. And in conclusion, This meta-analysis provide evidence that the data is adequate to support the routine use of antiviral in high-risk group for prevention of PTLD. What about using of rituximab? It can be used for post-treatment of EBV, viremia, and PTLD, but the most difficult question is who want to use it and what is the dose. So in one prospective study done by Van Eser in 2002, and this is done for hematopoietic cell transplantation, they used one dose of rituximab for 15 patients who had developed EBV reaction. They used the cutoff 1,000 EBV PCR and resulted to complete response in 14 patients and evidence by prevention of PTLD and complete clearance of viremia. In another group done by Amorelia and in 2011, and they used another cutoff for viral load more than 40,000 copies within first 3 months post-transplant, or if there is a significant drop in CD count with viremia. And for such a group, they found using of rituximab decreased the risk of PTLD to 1.4 versus 21% for those who didn't take rituximab, with no increased risk of infectious-related mortality. So what about treatment of PTLD? So using treatment of PTLD, it's different from according to PTLD subtype and type of transplant and from an institution to another. But the main regimen for treatment of PTLD, including reduction of immunosuppression without antiviral, immunotherapy including rituximab, chemotherapy, radiotherapy, and combination of both of them. Other treatment like adaptive immunotherapy with EBV-specific cytotoxic T cells. Sorry for this bad diagram, but this is including all the studies done for rituximab for treatment of PTLD, not for viremia. As we can see here, there is a prospective phase 2 trials, including all the studies using rituximab as a monotherapy. As we can see, the overall response is ranging from 44 to 64, which is quite good, but not excellent, with overall survival ranging from 47 to 67%, which is also, again, is quite good, but not excellent. But for PTLD trials, as for treatment of PTLD, they used 4 doses of rituximab with a CHOP regimen if there is a progression for the malignancy. Either they can give extended doses of rituximab, even 8 doses of rituximab with another cycle of CHOP if needed. This regimen achieved overall response reaching around 90%, with median overall survival 6.6 years, which is quite acceptable. So what about retransplantation? There is not very strong data about regarding retransplantation after PTLD. In a large cohort study based on Optin UNIS data, including 69 only patients, average time for a period for PTLD and retransplant was around 2.6 years. And during the follow-up, all this patient was doing quite good, with overall patient and allograft survival reaching from 86 to 74%. And another retrospective study reported the outcome in 6 patients with kidney retransplant after cure of EBV-related monoclonal B-cell lymphomas. As we can see, this is a more advanced lymphomas reaching monoclonal B-cell lymphoma, which is quite significant. And for such a group, they waited for a longer duration, ranging from 4.1 to 10.6 years, with even quite significant good cell graft and patient survival. So in most of the studies, the minimum waiting period was around 1 year post-complete remission. And for selection, for the next transplant, selection of better matched graft and avoiding of ETG induction, and even for a maintenance therapy, either lowest safe doses of CNI, MMF, and steroids, even using mTOR-based therapy, considered a reasonable approach. So back to our case, we mentioned at the first of our presentation, we have a 22 years old male patient He is 3 months post-transplant. He has EBV detection in the plasma, which is more than 300 copies. He's completely fine. He's maintained on triple immunosuppression, including tacrolimus, MMF, and steroids. We already need to know what is the cutoff number for considering this viremia is significant, when to start screening, what is the frequency of screening, what is regarding decision of immunosuppression, especially antiviral and rituximab, and if the patient have developed PTLD, what is the final decision regarding immunosuppression, antiviral, and chemotherapy. We have to revise some facts. Regarding cutoff, we don't know what is the cutoff. So if you have any viremia during screening, please don't get panicked and discuss with your virologist and ID about this EBV DNA results, and look for the trend and start to treat your patient with decreasing immunosuppression, as we discussed before. Regarding screening for PTLD and how frequent you need to screen, again, there is no right and wrong. It's based center from center. For our center, we have made a decision based on multiple factors, like what about PCR trend? What about the patient EBV serostatus? If the patient is donor positive or negative, so this patient consider high risk and will be more vigilant regarding clearing for PTLD. If the patient started to present with any symptom like night fever or sweating or weight loss, I will go directly for screening. Any labs abnormality, I will look for, as we mentioned before, if there is increase of LDH, hypercalcemia, hyperuricemia, so I will go ahead for screening for PET-CT or BAN-CT. And also for date of transplantation, as we mentioned before, the risk of PTLD usually increase in first year post-transplant. Regarding the reduction of immunosuppression, also we will have some debate and some differences between us. Mostly for viremia, for early post-transplant, I will not go for severe reduction of immunosuppression. I will go step by step. And even for switching for mTORs, it may be considered if the patient is low immunological risk with good matching and no DSAs. Regarding the antiviral treatment, we never use it for prevention. And also, as we mentioned before, meta-analysis doesn't show any significant. Using of rituximab for such a patient, if this patient not responding even with decreasing of immunosuppression, and I can't go further for a decrease of immunosuppression, I can consider rituximab as a good option. Especially we are just 3 months post-transplant, and it's difficult to expose this patient to a significant risk of rejection. And finally, if the patient is developed PTLD, what is the final decision of regarding immunosuppression? Most probably, most of us will stop MMF, decreasing tacrolimus, and even switching to mTORs, and using of rituximab plus or minus chemotherapy according to the severity and the histopathology. So let's summarize what we discussed today regarding risk factor. Risk factor for viremia, including immunosuppression, EBV serostatus, and previous history of malignancies. Clinical picture, it's non-specific, and extranodal manifestation is the most common. Screening pre-transplant using IgG, post-transplant by PCR, and there is no cutoff, and we don't know if the serum versus blood is more significant. Diagnosis of PTLD is based on clinical suspicion. Prevention and treatment of viremia can be done by vaccination, modification, and choosing the proper immunosuppression. Antiviral can be used, but with very weak evidence. Rituximab as a prevention and treatment for viremia, it can be used, but here it's a single dose, as most of the studies. Regarding treatment of PTLD, again, reduction and modification of immunosuppression, rituximab again can be used, but doses and frequency is much different from prevention of viremia. And chemotherapy, as we waiting duration is at least 1 year after complete resolution. And I will finalize my presentation with this quote. Its strength lies in our difference. So it's once we have a different opinion and different discussion, which I'm expecting after this presentation, this is strengths, not our weaknesses, and not in our similarity. And thank you.
Thank you, Dr. Rami, for your highly elegant and presentable lecture, comprehensive lecture, really comprehensive lecture about Epstein-Barr virus and PTLD. what is the nature of the Epstein-Barr virus starting from its discovery and its name according to the scientist that discovered it. Mode of infection, of course, we know it. Also, what is the virology and effect on kidney transplantation and various forms of transplantation. What is the recommended screening risk factors? What's the risk? Donor positive, donor negative, and the status of donor and classification according to the status of donor and recipient, and the screening, methods of screening, and finally, clinical picture of PTLD and modes of treatment in PTLD. Professor Ahmed, do you have a comment for this lecture?
No, يعني this is thank you, Dr. Rami, for this elegant, comprehensive lecture. And only one comment, يعني I think for prophylactic from viremia as regarding acyclovir and ganciclovir, I think it is doubtful. Dr. Rami mentioned it in the summary, but during presentation, you have one paper that it is effective for use of ganciclovir and acyclovir as a prophylaxis for viremia, Epstein-Barr virus viremia. Second, also regarding the most effective treatment for post-transplant lymphoid disorders, as you mentioned, Dr. Rami, immunotherapy is very important. Chemotherapy, use of rituximab. Sometimes if it is localized, we can surgical treatment. Dr. Ahmed Halawa can explain for us for that. يعني. The best treatment for high risk patient, I think, to avoid patient يعني as regarding induction therapy and the use of tacrolimus MMF, because it is increase the incidence of viremia post transplant. يعني this is what I can comment for this. This is a very elegant and comprehensive lecture from Dr. Rami. Thanks.
Thank you very much, Professor Ahmed. Professor Ahmed, comment, please.
Thank you very much, Dr. Rami. And the BK virus presentation as well as was very excellent. I'm quite impressed with the presentation, quality presentation, because both presentation pure English, no Franco-Arab, which is great. So, Rami, if you don't mind, you confused us at the end. I agree with Professor Ahmed Hassan. You mentioned you presented an article which showed that acyclovir and ganciclovir are effective, and then you deleted the conclusion completely when you presented the meta-analysis. So the meta-analysis is conclusive that antiviral treatment are not useful at all in the treatment of PTLD or EBV. Yeah. So I mean, this is actually could confuse the the reader. We should be very clear that meta-analysis, this is level 1 evidence, showed no evidence to support using antiviral treatment in the treatment of PTLD. We'll have to make it clear from the beginning. The second thing, actually, you mentioned that these patients with 300 copies, what would you do? Post-transplant patients, and you did PCR for some reason and came up with 300 copies. What would you do? I will tell you the answer. You do nothing. Because actually, if you screened those who are EPV positive and give them immunosuppression, usually they have copies post-transplantation, around 700, 800. So this is normal, for any EPV positive patients. So basically, you will do nothing, just monitoring. Rather, no reduction of immunosuppression. You don't do that. You don't do even CT scan. You don't think even of PTLD, but you monitor all these patients as usual. So you give me the impression that the 300 copies is something it needs more close monitoring, but it's not.
I think Rami recommended follow-up in his talk, Dr. Ahmed.
he mentioned that يعني every
I
2 to
mentioned
4
follow-up.
weeks. Yes.
For his follow-up.
Yeah. And
And also there is one comment more. What about vaccination up till now, 2024? There is no vaccination. There is only clinical
no
trials and
vaccination,
it's
yeah.
failed also.
Yeah.
Yes.
I mean, basically, it's high index of suspicion, PTLD. You know, to be honest, in spite of the monitoring, you see this patient in the clinic, and Rami know that they're losing weight, feeling unwell, having night sweat. We think of PTLD, but before we do that, we have to exclude infection because it could be severe UTI, it could be a transplant pyelonephritis or severe chest infection, or these days we have to think of COVID-19 as well and other virology. I'll go back to the BK lecture because, you know, the colleague addressed important point. I used to get confused when there is BK nephropathy and a suspected rejection. And I don't know the answer. But he kindly alluded that you check the urine for BK and check the blood, PCR for BK. If significant viremia is associated with a histological picture of BK nephropathy is most likely rather than rejection, because the problem of the treatment is different. You know, rejection, you augment immunosuppression, BK nephropathy, you reduce immunosuppression. Am I right?
Yes, of course. Yes. Yes. Professor Ahmed. Yes.
Yeah. Okay. Yeah.
معتصم.
This is the most difficult situation you can encounter, but most likely when you see a picture, bizarre picture of the histology, and there's query about BK and rejection, most likely it will be BK.
Okay. Thank you.
So sometimes we must يعني correlate between clinically and biochemically and also histologically. If there is a tubulitis, rapid increase serum creatinine, and massive lymphocytic infiltration, so I can go with a rejection, and so should treat this rejection. After that, we return back to the modifying of immunosuppression.
Yeah, this is true actually, but the usual picture of BK nephropathy when they affect the kidney, it damages the kidneys to the extent you can't tell is it tubulitis or not, is it a rejection or not. You can't tell, you know, bizarre cells and bizarre lymphocytic infiltrations. So this is a problem. You can't tell, the kidney is so damaged with BK nephropathy to the extent you can't tell whether it's rejection or not. But the clue here is viremia and viuria
Of course.
would direct you to one direction to another rather than another one.
Yes. Yes. Thank you, Professor Ahmed. Thank you.
Thank you, Professor
This
Ahmed.
is the
اتفضل يا أحمد.
viuria and viremia. This is the early stages of a BK virus before nephropathy.
Yes.
The end will be according to the PCR, of course.
Yeah. In theory, yes, but there is massive overlap.
Yes.
Okay.
You know, I mean, disease will never happen in stages. So viuria, then viremia, and then nephropathy. This is how it is described in the books, but usually there is massive overlap between them.
Thank you, Professor Ahmed.
I have برضو a comment, Dr. Ahmed, for this question. We already having these days a case. Patient was around 6 months post-transplant, and he was doing fine. Creatinine was normal. All of a sudden, he started to have some kind of AKI and rising kidney function. His creatinine was around 100, and now it's around 300 something, and with BK viremia. And we did a kidney biopsy, and the pathologist is quite sure this is only BK nephropathy without any rejection. And quite strange to see BK with a significant AKI just GFR dropping in quite 1 month or 2 months from around 80 to reaching around 15, which is quite strange. And there is, as you stated before, there is severe destruction, tubulitis, and plasma cell infiltration. And for such a presentation, you will have suspicious always if this is a BK nephropathy only, or there is a rejection with the BK nephropathy. Especially, we did an ultrasound and it didn't show any significant obstruction. Can be a reason for this significant increase of creatinine. So I have a question for such a cases. Do we have a cases of BK nephropathy with significant obstruction and there is no hydronephrosis in ultrasound? It can happen. I think it can happen.
I mean, anything can happen. Well, rarities are not the norm. By the way, we have here on, with us, Dr. Ahmed Saleh, a consultant nephrologist from Aberdeen. I think he did a lot of work on BK nephropathy. If you don't mind, Professor, will you unmute him because he has few questions?
Well, thank you. Yes. Yeah, it has been a great pleasure tonight to listen to both great colleagues and a great presentation. Thanks, Mu'tasim. Thanks, Rami, for great, elegant presentation. Regarding BK question that Rami has asked, yes, I spent the last 7 years studying BK. The BK guidelines for UK producer at the moment, so which should be published hopefully within next 2 weeks or so. Regarding Rami, yes, you can have a bit of urethral stenosis, which could not be picked up by ultrasound. You might need to do a CT-QP or plus or minus DMSA or any form of nuclear testing to detect the ureteric stenosis. Given the brisk AKI that the patient presented with, you are missing, or the team is not yourself. The team is missing a urethral stenosis here. If still a suspicion here, you can actually ask your urologist for opinion, and even diagnostic / therapeutic nephrostomy could be done. So yes, the short answer is yes. Back to Mu'tasim, if time allows, the confluence between the BK virus and rejection, it's a huge topic. I think no one, as all agrees, no one has an answer for it, and everyone has just case report from different areas. I remember back in the days, about 5-6 years ago in Sheffield, was Prof. Ahmed. We used mix of treatment, including IVIG, and at that moment, I think we had about 5 patients, and only 3 their graft has survived after IVIG with intensification of the immune suppression to cover for both BK and as well rejection. Regarding histopathological, I would say where the tubulitis is. If it's tubulitis just around the tubules or just beside the SV staining, this is more a BK, more than a rejection. If the tubulitis in other areas of your biopsy, but not around where SV40 staining, I would say that's most likely a rejection. So that's another possibly topic, differential to use or to guide your pathologist as well in your NDT discussions. Again, I don't think there is an answer between how to treat rejection plus BK, which of which, and the usual outcome is unfortunately graft failure, as all knows. Yeah. Thank you very much for unmuting me and giving me the opportunity. Thank you.
Thank you for being with us, Professor Ahmed, for sharing this and sharing your experience. Let me go through other comments. But before I have a question, please, to Mu'tasim, please clarify this point to me. You said that if you have a cellular rejection, it goes with picture of cellular rejection go with rejection and antibody-mediated rejection. What's your opinion on what the message you give to us with this, please? Can you clarify again?
What's the question, please? Again, Professor Yasser?
You said that the dilemma of rejection and PK
nephropathy.
virus.
Yeah,
If cellular rejection, it is cellular rejection. Okay, and if antibody rejection, can you clarify again the message you said, please?
I have said that sometimes the pathologist may diagnose or may have concurrent PK virus nephropathy and cellular rejection. And
Yes.
it's difficult to diagnose, especially cellular rejection, because the tubular interstitial infiltration is a common manifestation of both diseases, PK nephropathy and cellular rejection. But if the tubulitis is in areas in the biopsy away from the PK nephropathy sites or SCV40 immune staining, we can say that it's mostly a concomitant cellular rejection with PK nephropathy. While diagnosis of antibody-mediated rejection, we can depend on microvascular inflammation, positive C4D, glomerulitis and peritubular capillaritis, and fibrinoid necrosis. The criteria, the histopathological criteria of antibody-mediated rejection. I think it will be more difficult to differentiate between PK nephropathy and cellular rejection.
Yes, so the problem is mainly in the cellular rejection, and I think Professor Ahmad solved this dilemma by clarifying the point where is the relation of tubulitis to SV40.
Yeah, and yes,
I have one question also, Dr. Yasser. Dr.
تفضل.
Mu'tasim, what about the second transplantation from a patient who failed, have a failure graft, first graft يعني, due to PK virus nephropathy? And what is, there is any rule for graft nephrectomy before undergo second transplant or not?
Okay.
And also Dr. Ahmad Saleh can give his experience in that issues.
Okay.
Okay, Dr. Mu'tasim.
Regarding the retransplantation, of course, we can go for a retransplant if the failure of the first graft was due to PK nephropathy, but we should make sure that the PK viremia is cleared before the second transplantation. We may offer a plan of relatively lower immunosuppressive medications like induction by basiliximab rather than depleting antibodies ATG. We may maintain the patient in a steroid-free regimen if it is possible. And what's your second question, please?
There is any rule for graft nephrectomy?
Yes, I have said in the presentation, yes, although it makes sense because this graft may act as a reservoir for the infection, but the evidence and randomized controlled trials didn't show strong evidence to suggest nephrectomy before second transplantation. We should make sure that the PCR is cleared before second transplantation, which is more important.
Okay.
Thank you.
For Rami again, from Dr. Nawaf Naimi, what about the role of PK specific T cell assay in making the diagnosis?
The diagnosis? I think the diagnosis,
Yes.
for diagnosis, I think we still need PCR, plasma PCR, but I think PK specific T lymphocytes may act as like a predictive marker. It may give us an idea about the prognosis and reflect the immune status of the patient and whether the patient is at risk of persistent viremia or PK nephropathy, or we will suspect resolution of this infection. I think that.
Thank you, Mu'tasim. Please, Professor Faisal Shaheen wants to comment.
Thank you, Yasser. Thank you very much. I enjoyed the two talks, actually. Very brilliant from the two eminent nephrologists and to the target. Probably what I missed in this is the link between the immunosuppression, virus infection, and oncology. So if we have such link together, I didn't hear it from either Mu'tasim or from Rami that amount of immunosuppression was given to the patient can lead to activation of the virus and can lead to the failure of the graft as well. Probably this is the only myth which maybe I didn't hear it well But otherwise, excellent talk and excellent presenter. Thanks.
Thank you, Professor.
Thank you, Professor.
Please, Rami, start your other answer and regarding Epstein-Barr, and then we'll follow by Mu'tasim.
Okay, sure. So from the presentation, I can show it from the slides. Just 1 second. Again, I can go directly, I think. So regarding the effect of immunosuppression and activation of virus,
Yes.
yes,
Okay.
we as we cleared
ETG,
this
very
point here,
dangerous.
Dr. Faisal, there is a meta-analysis regarding the effect of ETG, and there is a direct relation between the use of ETG and risk of viremia, and also for risk of PTLD development post-transplant. And tacrolimus also increase the risk. For MMF and almituzumab, there is no significant increase in risk of development of viremia and PTLD post-transplant. Regarding rituximab, it's decreased the risk if used pre-transplant period. For belatacept, it's completely prevented to be used in seronegative patient, and it increased risk of PTLD, although it's a lower immunosuppression. And regarding mTORs, the evidence is very good for non-melanoma skin cancer, but for PTLD, the evidence is not sufficient because most of the studies, it was very limited cases, and they used a multiple approach, like they used more than one therapy for such a cases. So it's not proven this response is related to the shift to the mTORs.
Thank you, Rami. Thank you very much. It is clear.
Mu'tasim, you have a comment?
Yes, regarding the intensity of immune suppression, of course, if the patient is maintained on triple immune suppression, it will make more risk for PK reactivation. And regarding the type of immune suppression, as we mentioned, depleting antibodies, ETG as induction therapy, had more risk than basiliximab, and tacrolimus was had a risk more than cyclosporin, and MMF more than azathioprine. And tacrolimus, combination of tacrolimus and MMF, both had the highest risk for PK reactivation.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you, Professor Faisal. Professor Saeed Khamis, please.
Thank you, Professor Yasser, and thank you, Professor Mu'tasim and Professor Rami. Just I have 2 comments and 1 question, if you allow me. The 2 comments, it's the basic comments, actually. Number 1, regarding the conversion to to sirolimus, we should keep in mind if the patient has GFR below 40, we should not use the sirolimus. That's number 1. Number 2, regarding the PTLD, if you have CNS lymphoma, or PTLD, you cannot treat with rituximab as it cannot cross the blood-brain barrier. So you should use another agent. My question is regarding the, you focus, Dr. Mu'tasim, on the post-transplant screening of PK. What about the pre-transplant screening? Especially, I feel we underdiagnose the PK actually as a cause of graft failure or AKI in the graft, especially with, let me say, abuse or overuse or iatrogenic issue from us as a transplant nephrologist with using heavy immunosuppression, especially induction with these depleting agent, ATG, alemtuzumab, even in moderately or low-risk patients, unfortunately. So what do you think about the pre-transplant screening for both donor and recipient? Apart from the cost, I mean scientifically. And thank you so much.
Thank you, Professor Said, for your question and for attending this meeting. I have mentioned that high-risk serostatus, like positive donor IgG positive to a negative recipient, I showed that it had and it carried the highest risk for reactivation post-transplantation. And I showed also that, as I remember, that the viruria, donor viruria, also was a risk factor for reactivation. I think that.
So you are using it as a routine? I mean, like
no,
the EBV or CMV, we are not using as a routine.
No.
That's my question.
Yes,
so why not? What is the obstacle in front of this? Is it the cost or what?
I think we need an accumulating evidence in this issue. I think that
طب
because
can we
the
let
papers that
Professor
I
Ahmed
have
Saleh
read
to,
back to
if you don't mind,
60s
to
and
answer
70s.
also?
Oh, I
Professor Saleh?
think
Yeah. Okay. Yeah. Thank you, Mu'tasim. Yeah, I agree with what Mu'tasim has added, but the only other thing to think about, yes, the cost. So when actually we are developing the screening guideline or the guidelines for the BK virus, it's about the unity. So for example, in the UK, we have 77 units, but every unit has their own screening program. So how do you screen for the BK? And Mu'tasim has mentioned clearly plasma BK virus, for example. Actually, half of the units in the UK are using whole blood rather and the others as well using plasma. So that's also affect what you are using actually as a cutoff point for treatment, or is it 1,000 and 10,000, because it's dependent on what actually you are using in the first place. Secondly, I agree with Prof. Saeed comment is why you are not using it. Actually, there are ongoing studies at the moment, which I think Mu'tasim has highlighted rightly. Yes, we need to study that first, whether that will make a difference economically on or not on the long term. First of all, to detect whether the patient had viruria or viremia, both donor and recipient, and added to this, what is the genotype of the BK? That's more important, in my opinion, maybe because I just spent the last 7 years studying BK. What is the genotype? If the patient's genotype 4 and getting a transplant from genotype 3, is that considered a new infection? Or because he might have an antibodies already protecting him from genotype 4? Because as you know, we all know, we all catch it or were infected with BK virus long time ago when we were a child. But whether they are getting a donor from a genotype 3 and they have themselves as genotype 4, that's another thing to think about. So there are ongoing studies upon this. Just to add, it was actually a previous question of Professor Faisal about the oncology part, which is, first of all, EBV and BK. Myself, maybe as our child of our research was Prof. Halawa a long time ago, which was the oncogenicity of BK virus and the oncogenicity of it, and whether that itself is actually, is that related to immune suppression alone, or there is another evidence that BK virus itself has oncogenic character, and it can itself, like hepatitis B, for example. And given that is my area of study at the moment, yes, I would say there is a huge correlation, but we cannot prove the causation yet. So these were my comments about this topic. Thank you for again giving me the opportunity to discuss.
I
you.
think for this point we can comment. يعني most of the guidelines screening for immunosuppressed patient post transplant, not pre, because donor is immunocompetent and this infection is catches for early childhood 80% for all persons. I think يعني for immune competent no need from practical point of view. I think no need for screening for a donor before transplantation. Yeah, even recipients except. If it is a second transplant, he will undergo for second transplant, as we mentioned before, and the first graft is failed due to BK virus nephropathy. I think that, يعني, from my opinion.
Thank you so much, Professor Ahmed.
Thank you.
And no more comments. Now we
نعم.
reach it. Thank you, Mu'tasim and
Thank you.
Rami, for responding to our questions and for these two excellent lectures regarding viral infections. Thank you all, Professor Ahmed Thaqabi, for being with us, moderator for this session, and enriching us with your great experience. Thank you all professors who attended, Professor Ahmed Halawa, Professor Ahmed Saleh, Professor Faisal Shaheen, Professor Saeed Khamis, who were with us. Thank you for all attendees for sharing with their questions. It was a very rich night and very heavy scientific meal, but was very interesting. Thank you.
Thank you
Excuse
for
me.
all, and thank you, the Professor Yasser, for this meeting. Excellent meeting. Thank you very much.
Thank you. Thank you, Professor Ahmed.
Thank you.
Excuse me to close. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
عليكم السلام.
كل سنة وحضراتكم طيبين. coming عيد الأضحى.
إن شاء الله.
حضرتك طيب.
مبارك إن شاء الله
حضرتك
الأسبوع
طيب.
الجاي. كل سنة وحضراتكم طيبين وعيد سعيد على الجميع إن شاء الله. And meet you 2 weeks later not the coming Wednesday, next week. We'll meet you again in our same time, 9:30 p.m. Cairo time, inshallah, in a new meeting of Egyptian Society of Nephrology CME chapter meetings. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.